Good morning to all that have joined us, and a big thank you. My name is Charlene Rix, and I head up the SASFIN consulting team. With the World Health Organization declaring monkeypox a public health emergency, coupled with the new COVID variant sweeping through certain parts of the world, many of us are experiencing a déjà vu moment, leaving us feeling concerned and in many cases overwhelmed. It is for this reason I believe this webinar is happening in exactly the right time. I'm joined today by Dr. Chris van Straten, who will provide us with both context around monkeypox, how the smallpox vaccine provides us with protection, insights on what we have learned from COVID and what we are still learning, in terms of long COVID, the trends relating to non-communicable diseases, and I think most importantly, mental health. So whilst we're pressed for time, we do encourage individuals to post questions via the chat function, and we will endeavor to answer as many as we can during the Q&A session or part of the webinar. Just to note that we will be recording this webinar and we will make it available to all attendees about a week after. On that note, I would like to introduce Dr. Chris. Dr. Chris is the Global Medical Director of Clinical Governance at International SOS. In this position, he is responsible for the oversight and support of regional medical directors and teams in the implementation of all aspects of clinical governance systems, site medical reporting, data analytics, and remote site medical support. I really won't be able to do justice to Dr. Chris's experience, and therefore, without any further ado, I will hand over to Dr. Chris. And as a lead into the discussion, we'll ask him to provide a quick overview of his experience and what inspires him to do what he does. Thank you very much, Dr. Chris.
Charlene, hey, thanks for the great intro and inviting me to the call. It's always a pleasure to be here. So good, I will keep it short. It's very eccentric. As we discussed prior, I studied music first, 2 years of classical, 1 year of jazz, studied medicine in Pretoria, South Africa, and then spent a lot of time down in Cape Town working government and private emergency medicine. I liked adrenaline. So it was Vincent Bellotti and Christian Barnard and Bloberg Netcare and Tygerberg. And if you were in a car accident or in gunshot or having a heart attack, it was a good chap to have around. I also love traveling. So I worked for some time on the ships between Los Angeles and Mexico, and then Sydney and Fiji. That was super exciting because all these tropical islands like Vanuatu and Lifu. So I got to see amazing tropical places, but also some really interesting diseases. I joined International SOS 11 years back, working on a tiny island called Lihir, which is part of Papua New Guinea, northeast of Australia. And that was amazing. All the extinct volcanoes. Every day we treated malaria and dengue and snake bites. I even found an organism that hadn't been found before. And we got that genetically sequenced and published in an American journal. From there, I studied a Master in Science at the University of Edinburgh, focusing on global health. So increasingly, the older I get, and I'm hoping the wiser I get, that we're looking at the bigger picture. We've got to look at the global picture. How could we prevent pandemics? How do we manage the pandemics? And how do we keep ourselves healthy? That's really become increasingly my focus. So got a Master of Science from the University of Edinburgh in global health, specifically looking at data. How do we get data? How do we get accurate data? How do we then analyze that data and do useful things with that data? So Charlene, sorry, it's a bit of a long story, but that's me in a nutshell. A better way of putting it is just super nerd, super geeky nerd. That's a nice box. And I hope today's talk will be useful. So for those on the call, welcome. We've got a lot of slides to cover, so it shouldn't be death by PowerPoint, but the key topics we're going to touch on COVID. I've had a lot of extra questions this week on the variants, BA4, BA5, what are the patterns globally? So I'm going to touch on that. And then we're going to dip into what's increasingly showing up in our data. And when I say our data, that's international SOS data from our 1,000 sites globally and our clinics globally. And then it's also the data we're getting in from the WHO, ministries of health in the different countries. And increasingly, Charlene mentioned mental health. Mental health was a concern prior to the pandemic. The pandemic made it much worse. Many conditions before the pandemic, we were seeing improvements globally, improvements in South Africa, and we were proud of them. TB was stabilizing and coming down. Malaria, we hardly saw in South Africa, but certainly in other parts of Africa, coming down. Cancer, screening, detecting, management, improving. These positive trends, I'm afraid, some of it has been undone. So there's going to be some information here that some will find concerning, but you will see me often smiling, and I am still smiling. Why? Because it's amazing what we've done, and I am convinced that we will continue to make some serious inroads over the next months and years. Okay, so here we go. Brace yourselves. By the way, there is a place where you can put in your chats or a Q&A, because all these discussions, we've done hundreds of these sessions over the last 2 years, there's always a question that will pop up. Don't be shy, write it down. If we can't get to it all now, there is a Q&A session at the end, and or later we will be able to take email or correspondence. So first off, what is the global pattern? Oof, that's a big term. Polynomial graphing, don't worry too much about that. The main trend globally is actually kind of stabilizing and dipping downwards, but with exception. BA4 and 5 in parts of America over the last week, we saw this, or last month, 30% jump, 30% increase in cases, and in some of their states, severe disease, hospitalization, and an increase in deaths. Why? It's a very good question, and I'll help to answer some of that on the next slide. But in other parts of the world, like Portugal, we've seen those numbers actually stabilizing and starting to drop off. In parts of Western Europe, like the UK, the numbers are still reasonably high, but we think they're starting to flatten out, and mostly being driven by BA4 and 5. And why is that important? So this is the South Africa patterns and trends. Those are all the waves we saw, the Alpha, the Beta, the Delta, and then Omicron. This was us. Our Omicron wave was big. A lot of people got sick. There was a lot of hospitalizations, and then the numbers dropped off beautifully as people were getting more vaccinated. People were masking up. We South Africans do, we want to mark our plan, and we were doing it. And then we saw this blip, and we were all going, oh dear, here comes something. And remember, I'm proud of our South African scientists, and for good reason. We were the first to sequence BA4 and 5. It didn't start here, but we were the first to detect it. And what was interesting is we expected to see what's happening in America in the last month and in the UK. We thought that was going to happen here, but it didn't. This was our little BA4 blip, April, May. And it was a blip. It was a couple of cases spiked, but there were some hospitalizations, but not as many as we could have had. And there were certainly less deaths than we've seen in America and in Western Europe. Why? Well, here's what we think is happening. 1/3 of South Africans have been vaccinated, and a high portion of that, including me, I've been vaccinated, boosted, and double boosted. Why? I'm a healthcare provider, and I'm also going to do a bit of oversharing today. I have a rare autoimmune disease. I'm not going to tell you the name. It's a form of arthritis, and it means that I'm a high-risk individual. So if I get COVID, I am likely to get severe COVID, and I'm likely to end up in hospital. So I've been very, very cautious. So vaccinated, super vaccinated, and we know that 1/3 of the South African population vaccinated, boosted. We know that the other 2/3 have probably had COVID, and many had the Beta or the Delta variant. And luckily, that still gives you strong protection from BA4 and 5. And that's why we think this was a little blip compared to parts of the world where you'd expect, because they've got excess of vaccines, but there hasn't been a high take-up. There hasn't been as much masking and cautionary steps as we've taken. And our blip BA4 and 5 has actually been remarkably good. So that is a positive, but we need to maintain those gains, and we will dip into that throughout the discussion and as we proceed. So the question I've been getting repeatedly from different businesses and academics, and we've been discussing in academic circles, is why did we do so well? Are we testing less? And the answer is, to a degree, that our very smart colleagues, including Professor Mahdi at WITS, they're part of the teams that are tracking and monitoring. Our laboratories are excellent, and they're still tracking and monitoring and testing for variants, and they're testing sewage. So even if individuals don't go and report, or there's, I'm sick, but I stay home and I don't get tested, it still can end up in the sewage, and we can do the testing and pick up and therefore track what is happening in the country. So BA4 and 5, we had a blip. Our immunity, the number of antibodies in South Africa is actually high because of infection and or vaccination. BA5, by the way, does seem to be a milder disease that you still don't want to get covered. Someone like me, and I'm sure there are others on the call, who have a chronic condition, whether that's hypertension or diabetes or some form of autoimmune arthritis, we're at high risk. So I'm continuing to take those. I still mask up. It doesn't mean that everybody must mask up, but I certainly will do so. And my patients who are high risk are certainly encouraged to do so. And there was concern that it was worse, but it's in hamsters. So we know this, COVID can get into other animals, and it gets into hamsters and they get really sick from BA5. Sorry, hamsters, but for us, it's not that severe. And Eric Topol is a very well-known American scientist. I'm always reading his articles, and he was saying, yeah, it's got to do with the variants, it's got to do with our antibodies. It's also got to do with our previous exposure to the beta variant. So I hope that sets the scene a bit for where we're going next. Right, mental health. I'm actually becoming more and more passionate about mental health. The older, and again, hopefully the maturer I get. Why? Well, it's very simple. We know that prior to the pandemic, mental health was a concern for many people, and more people were, depending on the context and the cultural setting, starting to be able to talk about it. Remember, in some contexts, in some cultures, in part of the world, and some of the macho male Afrikaans background, and I'm pointing at myself, we couldn't easily talk about our feelings. It was seen as a sign of weakness. But I'm realizing more and more it isn't. It's good to be able to communicate effectively and professionally and to give support. And more than that, if you're constantly anxious or feeling depressed or isolated or lonely, it can and does impact on your cognitive ability. So your ability to complete work effectively, to be creative. So for us to be effective doctors, effective accountants, business people, effective fathers, husbands, our mental health needs to be a priority, because it does, it really does. And here's what we've seen during this pandemic. We've seen 42% of employees, and this was a survey we did in 2021, showing a decline or reporting a decline in the mental health, or having difficulty concentrating, or taking longer to complete work. So it is real, it is significant. What's been bad about the pandemic is it's exacerbated mental health concerns. Without a doubt, all of us at some point over the last 2 years has felt anxious or depressed or overwhelmed. And I put my hand up to this too. There've certainly been times when we've had to manage extremely sick, complex patients, stabilize them, medivac them in very remote and dangerous environments. And that is stressful. But here we are, we're going. And I'm still smiling because we're getting there. And what I'm proud about for our business, but other businesses too, going, okay, mental health, it's real. We must train people in how to identify. We call it mental health first aid. So how to detect when someone just having a bad day, or is something really impacting them? Being able to triage, provide mental health first aid. And if it's beyond your skill, your scope, being able to refer to a specialist, psychologist or psychiatrist. And again, that there's no shame. It's still the right thing to do and to provide support. Good. The next slide, this is not to scare people. By the way, I got an interesting message last week. I was on a forum and we were discussing COVID. And the thing with social media is it's an uncontrolled space and there's a lot of anger out there. And somebody wrote to me, "You're just a fear mongerer." And I was like, that's interesting. And then I was trying to think about why would someone feel that? And then I was going, oh, okay. If they don't understand where I'm coming from, what I'm trying to do is educate and show the relevant information so that we can prepare ourselves. Then it's a different context. So please understand this, everything we're showing you is about showing you what we're seeing in the patterns and trends so that we can prepare. And the analogy I use is like using a seatbelt in your car. Not only do I have a great seatbelt, but I always check my tires. I know that I've got a car with fancy sensors and don't speed. I'm very cautious and careful because I know what happens in car accidents. And it's the same thing. It's being prepared so if an accident did happen, I'm gonna walk out of that car and not be damaged. So when we look at this data, there tends to be an emotional response. That's okay, but what we need to do is look at the bigger picture. And what we're seeing is the following. We've seen it in South Africa. The first papers came out last year from the UK, showing that a lot of people that wanted to go for their screening, let's say screening for their testicular cancer or screening for a mole that wasn't looking good, like a melanoma, or screening for breast cancer, cervical cancer. During the pandemic, because of lockdowns or because of the fear of getting COVID, people didn't go for their screening. And then what they've started to see in the UK is people are presenting later when it's almost too late to treat or manage the cancer. And that's catastrophic for the patient and their families. So we are seeing this. We think there's an estimate is about 10 million patients. And this is from the UK in particular, I mean the US in particular, where missed their screening and therefore have ended up with a more severe form of cancer. And please bear in mind, if you pick up many cancers, melanoma, that's that skin cancer, or testicular cancer, or breast cancer, if you get it early and you detect it early, you've got a very high probability of long-term survival. So that's amazing. And I have family and friends that fit squarely into that category. If you don't pick it up early, that's when it can be catastrophic. So we do need to focus here. It's the education and realigning people and supporting them to go, hey, are you aware about the screening? We've all been so focused on COVID and we had to be, but now we've got to refocus on the other conditions that are part of our day-to-day lives and that sadly have been neglected during the pandemic. Tuberculosis. As a junior doctor in South Africa 20 years ago, we saw a significant amount of TB. And we were really proud over the last 5 to 10 years. 2019, I was feeling quite relaxed about TB because the numbers clearly showed a plateau and a drop in South Africa and in many parts of the world. That, I'm not going to say it's been completely reversed, but more, again, people were sick with COVID, they were coughing, they were feverish, so they didn't necessarily go to the doctor. It's when they were still coughing 2 or 3 months later and or losing significant weight and fatigued, then they went, TB was diagnosed, and by that time it had already caused damage. Still treatable, but we are seeing the numbers climbing and we need to be aware. And TB is super infectious from a droplet perspective. TB in a poorly ventilated space can hang in the air for up to 9 hours. And one thing you're going to hear, I hope increasingly, is people talk about ventilation in the workspace because it's important, not just for COVID. It's important from a tuberculosis perspective, from an influenza perspective, from other chemicals or pollution in the atmosphere environment. So we can, and we do, and we need to talk about it more. How do we keep our air clean, filtration systems, and good ventilation systems? Malaria, okay. Now, here I'm going to do a little bit of scaring, and let me explain the reason. In Africa, which is my main remit, I do have a global remit in our company, but I'm based in South Africa, and I'm involved with all the malaria cases we manage every single day for our clients in Africa. And the answer is, or the result is, every single day, I am either consulting on or supporting the treatment of a malaria case. And again, prior to 2019, the numbers were stable, if not coming down, depending on the country we're in. And that is significant reversing. And we think it's a combination of things. One, it's linked to changes in rainfall patterns in parts of Africa. So Northern Namibia, 10 years ago, I never saw a malaria case coming out of Namibia or Northern Namibia. The cases we saw were imported. The guy being in Angola or Mozambique or Botswana, and then goes to Namibia and gets sick, and then we test and he's positive for malaria. Well, 2 or 3 years ago in Northern Namibia, where one of our clients was operating, we were seeing people getting sick with malaria. Why? Increased temperatures, increased rainfall, made it easier for the Anopheles mosquito to spread and to breed and to therefore infect humans. The thing with malaria too is it's completely preventable. Malaria prophylaxis are tablets that you take prior to going into a malaria area. There are mosquito nets. I worked in Papua New Guinea. I've worked in many malaria areas for many years, 2 years extensively at one point. I haven't had malaria once. Why? Prophylaxis, mosquito nets, DEET impregnated clothing, and I didn't go out at nights to go party. Why? Because that's when the female Anopheles mosquito comes out. She comes out at night. The male doesn't carry the falciparum parasite. It's only the female for some reason. And she likes to feed dusk to dawn. So that's when you want to be indoors, covered up. And again, well-ventilated spaces. So please, for those of you traveling extensively, it's good to see business opening up again. It's good to be able to travel again. I love traveling, but I am super careful about malaria because it kills you fast. And what we've seen too is individuals traveling in Africa, business people, they go back to Europe or they go fly to Singapore. In Singapore, they start having a fever. The guy's got chills, he's coughing, or he's not feeling great. He goes to the doctor. Doctor does a COVID test, it's positive. And now they're treating him for COVID, fantastic. But he gets sick and he ends up in ICU. And then at some point, somebody goes, but hang on, wasn't he in a malaria area? And they go, oh, jeepers, okay, well, did we do a malaria test? No, do it. He's got complicated malaria, and that's what was killing him, not the COVID. And I've seen that repeatedly now over the last 2 years. You'll find it now in the literature. We're writing up articles on it. And also when we wrote it into our policy and procedure for how do we treat COVID and malaria patients for all our staff in Africa, you must exclude other infectious diseases like malaria. Okay, so please, the idea again is not to scare you. The idea is to say, for those of your staff that have to travel for work, brilliant, but keep yourself safe. And how do you do that? Up-to-date information and knowing what the risks are in the countries you are traveling to. Good. Now, this is a tough topic. It's not part of my daily functioning in terms of our sites are client-oriented sites and it's more business-oriented sites. But when you go look at the data, in terms of gender violence, especially in countries like South Africa, it really isn't, it's a disturbing picture. It's one of those numbers that I find hard cognitively and emotionally to process. And what was interesting, we were having a discussion in our company about, right, we want to get people back to the office. People working in offices tend to be more productive with supervision and interaction. But how do you do that safely? And some were saying, but hang on, at home, I've got all my amenities and I've got my ventilation and I'm less exposed. And someone's saying, please, can I come back to work? Because at home, I don't always have the support, or there might be issues there. And what's important here is part of that first slide on mental health, learning the triage and first aid skills, when to begin to think, could someone be experiencing violence or gender-related violence? And what are the appropriate referral mechanisms that need to be in place if and when you suspect that this could be happening? I'm afraid it's real, and it's something we do need to be aware of. Right, then long COVID. Right, I could opine on this for a very long time, but I've got to keep it short. Long COVID is interesting in that we don't yet have a full definition. Now, in medicine, we're incredibly pedantic. We want to measure something down to, on a microscopic level, pin it down. This is the definition. This is how it works. And for diseases like malaria and TB, we've got those. That's decades of work there. And it's very clear. Long COVID, there's two things we think are happening in terms of the mechanism. The first is, we know that this virus, one of my colleagues calls it the naughty virus. I think it's a little bit more than naughty, but it can and does get into, when you lose your taste or smell, that's the olfactory nerves being damaged. That's why you lose your sense of taste and smell, because the virus actually gets into those nerves and damages them. But most people recover their sense of taste and smell. There are some that haven't, or where the smell and taste is slightly skewed. They say coffee smells like burnt rubber, but most people recover fine. But recent studies too, and this is from samples done post-mortem and or from MRI scans, shows that the virus gets into brain cells and can damage brain cells. And that's probably part of that fog, mental fog that some have described. It might explain some of the anxiety and depression. The other aspect of it is, we know that the immune system mounts this fight response against that little virus. And that immune response is also what can trigger some of the symptoms and signs. So fatigue, brain fog, feeling muscle aches and pains, some of that is driven by the inflammatory response. And I'm sure you've heard them speak about this patient got severe respiratory distress and pneumonia from COVID. And what was happening there is that if the inflammatory system gets out of control, it can actually cause significant damage. And what we think happened in long COVID is either the virus is not completely wiped out of your system and causing these lingering symptoms and signs, or it's that immune response that's out of control and not resetting to normal and resetting to the state where you feel back to normal. And the science, we still need to figure out exactly what the mechanism is. But the reality is this: many of our patients and our colleagues who've had COVID are experiencing long COVID. And for some, it's debilitating. And in fact, parts of the UK, they've been saying that absenteeism is up and up because why they're seeing long COVID and people being affected by it. Another trend we saw in the data was, in my data I saw it initially, I was seeing increased cases of uncontrolled diabetes. And I thought this is because people on their remote sites or traveling were running out of their medications, or just were getting out of the habit of testing and checking. And then we started getting these reports coming in from United Kingdom, coming in from parts of the US and South Africa, showing that if you have had COVID and recovered, part of the long COVID picture is that you are more likely to get type 2 diabetes. And that is obviously worrying. So again, the emphasis needs to be on, we want to get vaccinated. Increasingly, the studies are showing us that the vaccine doesn't just prevent serious disease and death. It seems to be preventing or reducing the risk of getting long COVID and long COVID associated conditions like diabetes or myocardial infarction or heart attacks, stroke from the clots that the virus can cause. And in the UK, now this was done in February. It was a big survey done of businesses in the UK showing that increasingly there was absenteeism due to perceived or self-reported long COVID. The numbers at this point are still not crystal clear, and there's a lot of research being done on this, but we begin to think that this might be an issue should we not be prepared for it. Okay, so what are the solutions? Because a big thing about this, so we've just covered a lot of pretty challenging data. And I think a lot of people look at that and go, oh, run away. I am optimistic and I remain optimistic. And let me just do a bit of sharing, and I hope it's not overshare. So step one, I am Dr. Chris van Straten, right? I am a musician and I am a doctor, but I have a rare form of arthritis, which has made things really challenging for me. So one of the reasons I love making music and I love playing, but my hands are super sore when I've done it. And I have to, for example, take a form of immune suppression so that my joints can work normally, which makes me at high risk of a lot of the things we just discussed. I'm at extremely high risk of getting tuberculosis. I'm extremely high risk of getting severe COVID. So what have I done in my own life and my own practice to prevent those things from happening? Well, one, as soon as I could get vaccinated, I got vaccinated. I cannot overemphasize how important the vaccines are. By the way, most of us on this call, if you're over the age of 30, can thank vaccines, chlorinated clean water, sanitation, and antibiotics for the fact that you're actually alive, right? It's because of those developments, and we take them for granted every single day. I remember, by the way, the first cell phone that I had in medical school was that big brick, the Nokia. And now I've got my fancy Apple phone and it does all these amazing things, but I take it for granted, right? We take running water for granted. We take a flushing toilet for granted, but they save millions and millions of lives, right? So polio, my grandfather was a professor at WITS, professor of physiology. His generation, they either had a family member or a friend who had died from polio or had polio. I've treated 2 or 3 polio patients who were all elderly in my entire career. Let that sink in. Polio, by the way, should have been eradicated by now. We eradicated smallpox from the planet. Why? Because we built an amazing vaccine and all countries pledged to vaccinate 80% of their populations, and we wiped it off the planet. Smallpox killed 1 in 3 people that infected, and if you survived, you were left permanently scarred. I have never seen smallpox. I've only ever seen it in a textbook, right? So please, vaccines, they are absolutely crucial to what we need to do. So one, I am vaccinated to protect me. I'm also vaccinated to protect you and your family and loved ones, even though I've never met you. And I might never meet you, right? There's a much bigger picture here. Then I am still masking up and I will continue to mask up. And I'm not saying that you should all go and tell your colleagues and family to mask up. I am not saying that. What I'm saying is you need to be able to contextualize your work environment or the individual with the guide from a healthcare provider or companies like ours that can guide you and say, here are the risks in this context. Here's what you can do to mitigate that risk. So here's my example. Autoimmune disease, on immune suppression, fully vaccinated, boosted, wear masks always when I'm going into public places. And if I am sitting with family and friends, because I really am quite social, I do it in a well-ventilated space. And in that space, you can do things like filters or high flow ventilation systems. And in some instances, we do this in the hospitals. In the TB ward, there's UV lights that kill funguses, viruses, but they built not to be on humans, but to kill the organism. So raising awareness, that's what we're doing on this call. And I've had a thoroughly great time the last couple of months being on radio and television and giving these kind of talks, raising awareness. Cross-organizational, cross-sector partnership. That's what the pandemic has showed us, where we government with private, with NGOs, with the scientific community. The scientific community opened up all their research on COVID. It's unbelievable, right? And it's because of that that we're actually doing better than we could have been. Innovation and address identified gaps. Well, I'm a complete fan of tech. The fact that I can talk to all of you, right, in all your different places completely safely without a mask is because, again, this technology, like running water, like a vaccine that we just take for granted, right? Oh, Zoom calls, they're amazing, right? And then walking towards health equity. Now, one of the, how to put this, one of the most interesting things I did in the last years was doing training with the WHO on information and misinformation, because there's so much of it, right? Remember at some point, everyone was going, take ivermectin to cure COVID. False, categorically false. And that was a stressful time for us because clients, my own colleagues were coming to me saying, you're writing the policy and procedure on how we're going to treat COVID. Why don't you put in ivermectin, hydroxychloroquine, azithromycin, and a host of other agents? And my answer was no, because there is no proof. It turns out I was 100% correct. But more importantly, there are people with their own agendas who want to sell you things that could cause harm, right? So social media is amazing. I'm on Twitter, I'm on Instagram, I am on Facebook, I am on LinkedIn, right? But I'm always very, very cautious and respectful about what I post and what I say. And I will never share something unless it's been validated by people, not just me and my own knowledge. We all have bias. We all have the ability to view something or misinterpret something. So we have a system where we always double and triple check with academic institutions globally, in America, in the UK, in Germany, in South Africa, Singapore, etc. Good. And then working towards health equity. This is important. If we continue to allow areas, developing countries to lag behind, the risk there is that infections like COVID, like tuberculosis, the more people that get infected, the more mutations we will see. The more mutations we will see, the more it's going to impact all of us, regardless of whether you're in a wealthy country or in a developing country. So the equity component boils down again, not to just what can I do for me to protect me, but I'm also going to do what I can protect others. Because at the end of the day, it's like a boomerang. It will circle back. Okay. Good. We're going to start wrapping up shortly. This is just a recap of my feelings. We've got to keep our eye on the ball. So for those who are into sport like cricket or baseball or tennis, you got to keep your eye on the ball, right? The NCDs, the infectious diseases like malaria, like TB, now monkeypox, which we'll spend a slide or two on in a second. I think they've all been there, and we were doing so well before the pandemic. We really were, globally and in South Africa. But our eye was taken off the ball for a very understandable reason, and now we got to shift back and get our focus back on. And misinformation continues to cause serious harm. We've seen some truly sad and tragic events. One example was a young man who, when he heard from a certain president of a country that you could drink Jik and cure you of COVID, did so and got terribly ill and was in the emergency room. So please, when you see misinformation, please don't spread it. And if something seems too good to be true or it's too out there, just hit the pause button. And it's okay to say, I don't know. Let's ask somebody who does. And then telemedicine is part of what I studied, but we're just seeing more and more success. Before the pandemic, geeky nerds like myself were going, we've got these amazing tools. What if we had something that could measure my heart rate and how many joules are burned, or detect if I've taken a fall, or my heart is irregular, like an atrial fibrillation. And this phone, the smartwatch can do all of it. What if I could support someone in Nigeria who's currently struggling with malaria or monkeypox? We treated 3 cases of monkeypox successfully in Ghana and Nigeria in the last 6 weeks. And all my interactions with those cases and the doctors treating were via telemedicine platforms. That is amazing. When I was a doctor at medical school with my big brick of a phone, I'd never thought that could happen, but it is, and it's just going to get better. It's why I'm not sitting here going, oh, it's doom and gloom, because it isn't. They're amazing tools, and what we've got to do correctly is identify the gaps and build this well-being maturity curve. Now, there's a company in South Africa that's famous for its insurance. I'm not going to mention brands. They're famous for their insurance and their health trackers and their driving patterns and trends. And the reason I love that particular company is they're using smart data to really drive change. Because if you can't measure it, you can't improve it. That, by the way, comes from a very famous computer scientist called Peter Drucker. And it's so true for everything in life. Medicine, music, engineering, maths, banking. If you can't measure it, you can't improve it. So what we know globally, and we've had the privilege of working with global companies and also local companies, and some are still finding their feet. And you can see companies when they start reaching a level of maturity in terms of how do we pick up patterns and trends? How do we support staff in terms of education, but not just educating, empowering? It's all very well having a nice talk and I say some great things and, oh, you know, I've done some lovely things and I've saved some lives. That's great. But if you don't come out of this talk going, I know where to find good information, and there's a whole slide dedicated to all the references that went into this talk, which will be shared with you. Where do we get good information? Who do you partner with? So with me, and again, I'm using me because it's sometimes easier to relate to a personal story. So me as a doctor, I have a GP and I've got a rheumatologist, a specialist who've walked this journey with me for over 30 years. They're the reason I'm alive. They're the reason I'm productive. They're the reason I still have a smile on my face every day and want to get up in the morning and do something. Because without them, the condition I have would have left me crippled and incapable of working. That's just a fact. But thanks to technology, amazing medications, vaccinations, I'm not only alive and fit, I'm alive, fit and kicking and doing a fantastic job. That gives me a sense of fulfillment and satisfaction. And the truth is, I'm still part of a unique person or profile who's got all those luxuries. And what we've got to do is make sure it's not just highly educated, capable people with resources. We've got to make it more widespread. And we now have the technology, the insights, and the partnership. So all of us should have a GP or a healthcare provider that knows our story. And it's my belief that all companies should have a health partner. Some big companies do. They've got a chief medical officer. Some companies can't afford that profile, but they partner with institutions that can and do. So there are different ways of doing it. But if done correctly, there is significant success. It's interesting with mental health. There was a US paper that came out 2 months back stating that about for every dollar put in to mental health and wellness, you gain $4 in productivity and positive outcome. Now, if you do that on a scale of billions of people, the numbers become very significant indeed. Okay, case study. It's always easy to talk, you got to prove it. This wasn't easy, by the way. What I'm about to show you is a client, it's a European client that I've been supporting for the last 3 years. They've got assets globally. Several of those assets sit in Africa, some are South America, Europe, Scandinavia, and then in Asia. And over the last 2 years, specifically for them, one, they didn't have good data. So the first discussion 3 years ago was, we need to have a data source that's safe, secure, HIPAA compliant, GDPR compliant, POPIA compliant. What does that mean? That means if it's private information, it's anonymized, it's secure, and legally interpreted or analyzed in the right manner. Once we've done that appropriately, we could then see where they were at risk. Malaria stood out like a sore thumb because many of those assets are in malaria endemic areas. Secondly, COVID. In some jurisdictions and ministries of health would shut down a factory, or they would shut down a vessel if there was an outbreak. And for 18 months, we kept all their assets around the globe COVID-free. And that was done through education, vaccination, screening, isolation, and retesting before deployment to some of these sites, and then continued monitoring on board, plus the ventilation that we spoke about, plus the masking, the hygiene, etc. And it was fascinating. The first outbreak we had with this client was actually beginning of this year, when Norway government said, we lift all restrictions. And the client said, hey, well, the government said, so we did. Outbreak, and immediately it affected their productivity. Whereas my personal communication at that time to them had been, I would have reduced those restrictions, but when you're in the close environment working with other people, personally, I would have continued with that. And that's where it's challenging, because you've got the government on one hand saying, hey, we need to keep the economy going. If the levels are coming down, fine. But for at-risk groups, or in particular contexts, that doesn't always make sense. And what I'm incredibly proud of and hoping to publish on in the next couple of months is the fact that we've kept them malaria-free completely. That was no small task, by the way. Extensive malaria training, reach out sessions, webinars, all taking prophylaxis, mosquito nets, and then being able to access a healthcare provider 24/7 if someone became infected. But in fact, not one malaria case occurred on those particular assets. So it can be done. That's the moral of the story. Not always easy, and it didn't just happen overnight. Extensive thought, planning, risk versus benefit, and then also the cost. It has to make fun or the comparison of my story as someone who's had a long journey of over 20, 30 years of an autoimmune condition, having the support of highly skilled healthcare providers, and then me having to take ownership of that and go, right, I can't go and do X, Y, and Z because it could put me at risk. But I am going to do A, B, C, and D, and I'm still here. And the same applies to the working environment and to our colleagues. Okay, that's a huge amount of information. Take a deep breath. And what I'm going to do now quickly is just a quick touch on monkeypox and how it relates to South Africa. There's a lot of information out there, and you'll find it on the WHO website. You'll find it on the NICD. That's the Institute of Communicable Diseases South Africa. They've done an amazing job at keeping all South Africans safe and tracking the numbers and testing. In South Africa, we are a non-endemic country. So we saw 3 cases, and they were all basically in the last couple of weeks, and they were all, to my understanding, imported cases. So what we're not seeing in South Africa is spread from human to human. and we hope it stays that way. But what's important is what we do next. Now, what I've been asked to is, how did this happen? How did it go from being endemic in West Africa and Central Africa? Because it has been, by the way. If you go look at the case studies and where did it originate from, there's the central clade in around the DRC, and then in West Africa, Nigeria, Ghana, every couple of months there are outbreaks, but it's mostly exposure to bushmeat or rodents. And by the way, it's called monkeypox. It should actually be called rodent pox. We don't know, we haven't confirmed this, the host yet. We think it's actually rodents, large rodents, like something called a pouch rat. It's about the size of my head. And it's used to be caught and then sold in America as a exotic animal. And there was an outbreak of monkeypox in America in 2003 because of the illegal trade of rodents and ground squirrels. So outbreaks occur in West Africa. We've managed 2 children aged 10 and 11 in the last month. There it was animal contact, and then the brother was in the same room as another individual. So monkeypox, you get those lesions, the pox. And in the beginning, it's a lump, itchy and uncomfortable. Then it becomes a fluid-filled vesicle, a blister filled with clear fluid. Then it becomes a blister filled with pus. Then that breaks, it scabs, and it heals over. And the spread was someone in Nigeria going up to big rave type parties in Spain and in the Belgium, Holland, close physical contact, some of it sexual, but maybe just close contact with these lesions. And that's how it spread. And it's predominantly in these sexual networks with men that have sex with men. But that doesn't mean it's a disease that is specific to that group. Anyone can get monkeypox. There are doctors that have gotten monkeypox from treating these patients. Okay, so please, what makes it unique is that it's now significant human-to-human transmission, but mostly in that particular demographic. And it's really important. It's not an STD. It's that close contact that mostly spreads it. And we must not stigmatize this disease unnecessarily. The other question I had, and this is my final slide, and then it's open to questions. Sorry, I went on longer than I intended. Symptoms and signs. In the beginning, it's like COVID, it's like malaria, it's like cholera, it's like flu, headache, temperature, fever. What's interesting though, is these very large lymph nodes. It really is very characteristic. And we've seen it in most of the patients that we've managed. So headache, fever, and a history of contact with somebody that might have been infected. And then you start with the pox lesions, usually where you first had contact with the individual that was infected. And then in the beginning, it can look like chickenpox, but by the way, different viruses. Chickenpox is a varicella, it's a different family. And then the orthopox, that's monkeypox, smallpox, cowpox, they are related. And that's why you'll hear people saying, well, my mother got vaccinated as a child against smallpox. And we think that that immune response from that is probably protecting individuals from monkeypox. Okay, good. I think I've spoken way too much. I apologize for going on, but I really am passionate about this topic. These are the references, they will be shared. The disclaimer really just says everything that was given is it's based on the current evidence, but it can and will change because the world is changing and the science is changing. And it's my responsibility to have done this well. And if there's an issue, it's with me and not International SOS. And then finally, any questions. And again, if there's too many questions or we'd run out of time, you're welcome to post those questions and we can see if we can answer them at a later point via email or other form. Thanks so much, Charlene, over to you.
Thank you very much, Dr. Chris. I think your presentation was extremely informative. So a lot of the questions that I had got from clients prior to this that I've written down, I think you actually did address. We do have one question in the Q&A. And it is around that long-term COVID. And I think a lot of people are looking at, so the question is, would you be able to share, COVID illness conditions? And it seems like there's a lot of symptoms. And I think some people even believe that every time they go and say, listen, I'm feeling like this, and then it must be long-term COVID. So how do we know, is it long-term COVID, or, what are we seeing as, I know you did a slide, but it is still quite out there, I think.
It's still difficult to get your head around. And for a lot of doctors, it's still difficult because it isn't an exact definition yet. Because we're still trying to figure out, is it because the virus lingers on and on? Or is it because the virus might be eliminated? We know in some individuals, your body has wiped it out because of those antibodies that you built up from the vaccine or your own immune system, and it's gone. We can't find trace of it. But we do know that the inflammatory response sometimes doesn't settle down. So your body just keeps fighting. It wants to fight something. The COVID's gone, so heck, it's going to start beating you up. By the way, that's how a lot of autoimmune diseases work. That's how the arthritis that I have works. My immune system got triggered 30 years ago and never stopped. And it mostly beats up my joints, thinking, you're some bad bacteria or something, but it's not, it's me. Okay, so long COVID, what we still don't know 100%, is it because the virus is lingering somewhere? Like perhaps it's lingering in part of the spleen or part of the lungs or in some of those nerve cells in the nose or perhaps the brain, that's triggering a continuous immune response, and that causes the fatigue and the tiredness? Or is it the virus is gone, but it's now triggered an autoimmune disease? So it's going to take time and a lot of research to figure that piece out. But from a symptoms point of view, some important steps. One, obviously you need to have had proven COVID. Two, those symptoms that a lot of people experience, like that fatigue, like the headache, like the brain fog. When I first heard about that, I was like, that sounds odd. Seriously are reporting that they can't memorize as easily, or it's taking them longer to do basic work that previously they would have done quickly, or joint aches and pains. So if you're having those symptoms and signs about 3 months after recovering, and we've excluded other conditions that could cause those symptoms and signs, then we're going to say it's probably long COVID. And they've already started, there are things that can help. So graded exercise regimens, making sure that you rest appropriately. But like I said right at the beginning, if you miss that you've got malaria, well, you're going to know very quickly because you're just going to get really sick really fast. Okay. So it's a doctor's responsibility. If you think you've got long COVID, you've got to exclude the differential, make sure it's not something else. And if it's probable that it's long COVID, to go part of the support systems that are being put in place to support and rehabilitate people with long COVID. Does that help?
Yeah, definitely. I think like you say, it's still not, whilst it's medicine, it's still not a complete science. We still need to understand what is impacting, and also, I suppose, my body would react different to yours, and what have you. So again, a bit of a debate. I think one thing, that came clearly through to me through your presentation was how important vaccinations are. But I do think that at the moment, most of us, I think, have had like the first vaccine and the second one, but now with these boosters, I think the question is, when is it going to end? Because of the different variants that are coming out all the time, it's like, am I going to have to do this annually, biannually? And if I've got the immunity from my first vaccine or having COVID, why do I need the booster?
Excellent. That's a brilliant question, by the way. It's a deeply insightful question. Okay, so first off, it feels like forever that we've been in this pandemic, but it really is 2 and a bit years, right? And if you look at the amount of science that we've already achieved, it's remarkable. But there's still, like you said, the next variant, what are we going to do? But I'm optimistic. Here's why I'm optimistic. 2 papers came out yesterday, so it's fresh off the shelf, but the research isn't that fresh off the shelf. Okay, so let's start with this. The current vaccines are injected. So they're really good at making your antibodies go up and really good at your innate. That's a cellular, those are the big cannons. So antibodies are good at preventing infection. And it's
Okay.
your cellular, that's the big cannons that's good at preventing severe disease, pneumonia, hospitalization, and death. Okay. But so the cellular immunity goes up, antibodies go up. Over a couple of months, the antibodies drop, right? The cellular stays strong, but the antibodies drop. So you're more likely to get reinfected by a variant or something. So yeah, we're saying this thing's clever. It keeps dodging.
Mm.
And that's why we're creating these new vaccines. But here's why I'm optimistic. One, there is research being done on a or a pan-coronavirus vaccine. What does that mean? It means all the vaccines to date have been built around the spike protein. Now, the spike protein's been changing and mutating on the virus, but there are other parts of the virus, the capsule, that hasn't mutated. If you create antibodies against that, doesn't matter which variant it is, it's going to take out a coronavirus, whether it's alpha, beta, delta, or omicron. And it's currently being tested. So I'm hopeful about that. Two, nasal vaccines. That would be such a game changer. Why? Because it would be sprayed in the nose. A lot of people hate needles, right? I'm used to them. So, hey, I've injected people and I've been sick a lot. So I've had a lot of vaccines and a lot of injections. But a lot of people are seriously scared and can't go around scaring people. So a nasal vaccine be easy to give. It would probably reduce getting infected, because that's how COVID normally gets in, through the nose and the mouth. And so one, it should significantly drop infection rates. And that should help us to also build your innate cellular response and your antibody response. So two things to keep an eye on. It's going to take another 18 months to 24 months, but they're in research, they're in some of the final trials, and that could be a game changer for us, all of us.
Okay, yeah, I must say, it seems a lot less invasive, I suppose, than the injection and what have you. And I think also for smaller children, because now, the way I understand it, our younger kids can go, but often they are nervous about having an injection and what have you. I think the last question, because we're a bit over time, but maybe the last question is around, and I mean, you mentioned it in your presentation about misinformation and the fact that vaccines have sort of taken out polio, that we don't have polio cases, pretty much eradicated smallpox. And I mean, and now that smallpox vaccine has come back and really shown positive impact on the monkeypox, for example. So protecting us against something else that wasn't even attended to. But there is a lot of anti-vaxxers out there. And I think specifically as individuals, where you've got them in your group of friends or family, as well as in a company setting, there's a lot of misinformation about by being vaccinated, and some people have already said that having the COVID vaccine is actually what's made them ill, not the actual COVID virus. What would you tell people on how to deal with that type of feedback or thought process that is rearing its head?
Yeah. Okay, so great question, and I wish we had 3 hours plus to discuss, because it's something that I like to be calm and focused, but I've struggled. I've really struggled with this. So first off, I think it's really important to note that people have different reasons for saying, I don't want to get the vaccine. And some of it is completely legitimate, right? So if you're dead scared of needles, it's not your fault that you're dead scared of needles, right? I'm not, and it's easy for me to, be a doctor and do what I do. But for other people, it's hard. So we need to, I don't think confrontational stance works. It's never worked for me, let's put it that way. 2, my own staff, that especially in the beginning and when it came up about vaccines or ivermectin, who then contacted me privately and had a one-on-one session saying, hey, these are my concerns. I don't understand the science, or I don't understand the risks. Because, by the way, some of the maths behind this is really complex, and I don't even claim to know all of it. But for a lot of people, it's super intimidating. So what has been really useful is using the right metaphors, non-confrontational, and guiding them to the sources that are accurate and trusted and don't have to my mind, a hidden agenda. So again, it's WHO, it's CDC, the Africa CDC has actually done a great job. Then it's NICD in South Africa, the American CDC, I thoroughly love and have been reading for years. So find your trusted source. And by the way, you never trust a individual or a source. That's not how medicine or science works. It's, we look, if you have a theory or postulate, it's always we challenge it, we test it, and if it's false, then you got to prove it. Or if it's right, you got to prove it. So one, try and understand what the fear is, what is the context. And a lot of people, it's actually just not understanding or a fear. And once you've contextualized it and given the right metaphor, a lot of people are going, oh, okay, I get it. Okay, I'm going, hey, Dr. Chris, 2 weeks later, hey, I've got my booster and I'm actually doing fine. And it was sore for a day or two, but I'm doing great. Awesome. Then you do get what I would say, the extremist anti-vax. And I really do struggle with this. And I have a family member who falls into this category. And as you can imagine, we don't talk much. In fact, we haven't spoken during the past 2 years. And I find that deeply sad.
Yeah.
Well, here's what I think, and maybe I'm wrong, but I think that it's more to do with the psychology of control and power. Some people, I think it's about anti-government or anti-establishment. So even if it's totally logical, like you can chat to the person about their car and they wouldn't hesitate putting on brand new tires, wearing a seat belt, putting in new spark plugs, whatever, just to make this car go. And it's all by the way, the logic behind that, the maths, the science, the physics, the chemistry that makes a car go is the same logic, science, and chemistry that goes into building your vaccines, right? The level of complexity is order of magnitude bigger, but it's the same science, if you think about it, fundamentally. And when I've had this discussion with this individual, it was always just no, and it's a conspiracy. And then I just tactfully and respectfully said, well, obviously I can't convince you, and that's okay. But it does sadden me because my thinking has always been around not just what's good for me, but what's good for my mum who's elderly, what's good for friends or family that might be at risk. I'm always trying to think of what's the bigger picture. So yeah, I don't have all the answers to that, but that's been my approach.
Okay. Thank you very much, Dr. Chris. As I said, we're a bit over, but thank you for your time. I found it extremely informative, and I'm sure, the people that have stayed on, so I think they also did find it very informative. So what we will do is we will be, we've recorded the session and then we will share it. If we get any questions subsequent, then what we'll do is share it with you, and hopefully we can then maybe put a Q&A out if needs be at a later stage. And then we'll obviously keep in touch with you and our clients that have joined us on the webinar. Please reach out. We are in partnership with International SOS to offer, as you mentioned, that clinical reference points where smaller companies might not have a clinical team to help them. Then we can, where needed, put you in touch with International SOS and try and assist you to put together policies or procedures for your South African staff. And if you obviously are sending people over border in Africa or even overseas. So thank you to everybody for your time, and we'll see you at one of our next webinars. Have a good day.
Stay safe and stay informed. Thanks so much.
Thanks, Dr. Chris.